Good morning, good afternoon, good evening, depending on where you are. Thanks very much for the organizers to the invitation to present today. It's a pleasure and an honor to be here with Sheena and Ken and you all. Today, I will provide a brief review on the clinical experience with long-acting PrEP. My presentation will focus on data from HPTN-083 as more in-depth analysis on HPTN-084 are still ongoing. I will present on three main aspects: the impact of CAB-LA on the detection of HIV infection, the impact of CAB-LA on emergence of HIV drug resistance, and the analysis of drug concentrations obtained with oral CAB and long-acting CAB injections. Just as a very quick reminder, HPTN-083 study is an ongoing phase 2b/3 randomized double-blind multi-center study comparing a PrEP regimen containing every 8-week intramuscular injectable cabotegravir LA to daily oral TDF-FTC among cisgender men and transgender women who have sex with men. Participants were enrolled at 43 sites across the world in US, Brazil, Peru, Argentina, Vietnam, Thailand, and South Africa. Important to highlight that the study had specific metrics for specific populations for inclusion of 50% Black MSM in the US, 10% transgender women, and 60% participants less than 30 years of age. The blinded study portion of the study was stopped by an independent data safety monitoring board as a result of superiority of cabotegravir LA compared to the TDF-FTC. We originally identified, as you can see in this slide, 13 incident HIV infections in the CAB arm for an overall incidence of 0.41 per 100 person years, and 39 incident infections in the TDF-FTC arm for an overall incidence of 1.22 per 100 person years with a hazard ratio of 0.34. As Sheena already presented, this is the pre-specified HIV testing algorithm that was used at the site and at the central lab that was at Johns Hopkins University. After unblinding, the need for more extended back testing was identified, and post-hoc additional central testing included additional back testing using the Aptima qualitative RNA, additional antigen antibody and discriminatory antibody testing, and the use of single copy RNA at selected visits. Quantitative viral load testing also helped identify samples that were suitable for HIV resistance testing. The pre-specified pharmacology plan is also shown here. As I mentioned, the pre-specified testing algorithm identified 13 incident and 2 baseline HIV infections in the CAB arm. We identified these cases as belonging to group A if they were found to have acquired HIV infection prior to the administration of any of the study products. So A1 and A2 were participants who, although not detected on site-based testing at enrollment, were found to have evidence of HIV infection before exposure to cabotegravir. Because of the absence of detection of the HIV infection at the site, they did get exposed to study product. In one case, just oral product. In one case, oral and injectable product before seroconversion was identified at the site level. For the B cases, it was fairly easy to understand how HIV had been acquired since there had been a prolonged hiatus since last cabotegravir administration when HIV infection was detected, with at least 6 months since their last administration of cabotegravir. C1 to C3 were participants who were found on retrospective testing to have acquired HIV during the lead-in period. These percentages that you see next to each case number represent the pill count-based adherence to oral study product. During the oral lead-in, you can see that the absence of ability to detect HIV infection at the site level resulted in injectable study product being administered in 2 of these cases. And finally, we reported 5 cases where HIV was acquired despite largely on-time cabotegravir injections. The extended testing employed post-hoc revised the adjudication of time of first HIV positivity in 2 cases. The reversion of the Aptima testing most impacted 2 of the cases that we had previously reported, D2 and D5, shown here boxed in red on the slide. In D2, it moved back a little, but for D5, it actually revealed evidence of HIV being present prior to the administration of study product. So D5, again, watch the animation, now got renamed A3, since that existed prior to the study product. And we also found an additional on baseline a prevalence case that we named A4. So that left us with 4 baseline infections and 4 D cases rather than 5. So this minorly updated the incidence rate in the cabotegravir arm and minorly updated the hazard ratio that we calculated, although it did not change the interpretation of this primary data. In the TDF-FTC arm, breakthrough infections were defined as having plasma and dried blood spot drug concentrations consistent with good adherence to daily oral dosing at the time of the CAB of the first HIV positive visit and at key visits before that visit. In the CAB arm, breakthrough infections were defined as having target drug concentrations higher than 8x PAIC90 at the first HIV positive visit. I will now review the pharmacology and virology of the observed infections, beginning with group A. On this slide, the first HIV positive visit, as identified by site-based testing, is shown by a blue vertical line. The first HIV positive visit identified by the central lab testing is shown by a vertical red line, and cabotegravir injections are shown as vertical green lines. CAB concentrations in plasma are identified by orange dots, and the dotted horizontal markers represent 1x, 4x, and 8x PAIC90, which correlated with thresholds for rectal challenge prevention in non-human primate models. Of the 4 baseline infections in the CAB arm, 1 of 4, case A2 in this slide, was found to have treatment emergent integrase resistance, characterized by a K148Q and E138K mutations. Interestingly, in 1 participant, case A3 on this slide, escape viremia during the PK tail did not lead to integrase inhibitor resistance. In this summary slide, we had 4 cases in A as baseline infections. 1 had resistance-associated mutations consistent with integrase resistance. 3 of the 4 were virologically suppressed on ART, and 1 of the 4 was lost to follow-up. So moving to the group B, these are participants who had no recent cabotegravir exposure. So this is the 5 of them. 3 of the 5 likely acquired HIV during the pharmacokinetic tail. These are cases B1, B3, and B4 on this slide. Importantly, none of them developed integrase resistance. So this is the summary of the B cases. So we had 5 seroconversions with no recent CAB exposures. This is group B. 1 had transmitted resistance to NNRTIs. 5 of the 5 were virologically suppressed on ART. So the group C infections were those that occurred during the lead-in, and I think are quite interesting and very illustrative. Only 2 of these cases had drug concentration evidence of cabotegravir exposure. These are cases C1 and C3 on this slide. C2 basically never took the drugs. Both C1 and C3 had been exposed to cabotegravir LA and developed resistance, integrase resistance mutations with K148R and accessory mutations in both cases. So this is the summary of group 3. 3 seroconversions during the oral phase, 2 developed incident integrase resistance associated mutations. One was virologically suppressed on ART, one was lost to follow up, and one there was no information. So we are now moving to group D. These are the ones who were originally identified as 5, now they are 4. There is tremendous interest in trying to understand the correlates of protection as these seroconversions happen with good levels of cabotegravir. And I'm gonna show each of those with each of these with more detail information. So case D1 was detected on the site-based testing algorithm after 10 CAB-LA injections, and central lab testing identified the infection 16 weeks earlier. Cabotegravir concentrations were consistently around 8x PIC90, with the exception of a decrease to just over 4x PIC90 between injections 1 and 2. A genotype was not obtained due to low viral loads, and boosted PI-based ART has maintained virological suppression subsequently. Moving to case D2, this case was detected on site-based testing after 6 cabotegravir LA injections. Central testing retrospectively identified the infection 14 weeks earlier than the site. Plasma CAB concentrations were consistently 8x PIC90 during the injection phase. Interestingly, because of discordant testing results, this participant did not accept the diagnosis of HIV infection and refused suppressive ART, assessing 1 month of boosted PI-based PrEP 2 months after the diagnosis. But then ceasing ART thereafter. We have been told anecdotally that these participants subsequently had viral load increase to approximately 3 logs, and integrase genotype failed to amplify, but has suppressed on a boosted darunavir-based ART regimen. Case D3 was detected at the site after 5 cabotegravir LA injections. Central lab testing identified the infection with K103N containing virus 17 weeks earlier than the time of detection at the site level. Central lab integrase genotyping additionally found the R263K mutation. Plasma CAB concentrations were similar to case D1, and we again saw approximately 8x PIC90 and a decrease to just over 4x PIC90 between injections 1 and 2. The participant suppressed well his viral load on a boosted PI-based ART regimen. And finally, case D4 was detected at the site after 4 CAB-LA injections. Central lab testing identified the infection 6 weeks earlier. CAB concentrations were again approximately 8x PIC90, with a decline to approximately 2x PIC90 between injections 1 and 2. Although detected at the site at week 24 on study, a delay in initiation on ART due to programmatic issues with linked to HIV care was associated with escape viremia to the 5-log level and identification of integrase mutations K148R and G140A before TDF-FTC efavirenz treatment resulted in full virological suppression. And this is the summary of our D cases. 4 seroconversions, 2 had resistance-associated mutations, 1 with integrase mutations, and 1 with integrase and NRTI mutations. 3 of the 4 were able to be virologically suppressed with standard ART, and the fourth patient has irregular follow-up. So here are the key virology findings for the CAB arm. CAB exposure was associated with prolonged suppression of virus replication and delayed antibody expression. We had a median 62-day delay ranging from 28 to 72 for prevalent cases and 34 days for the TDF-FTC arm. median 79 days delay ranging for 38 to 185 days for incident cases, and this was 31 days for the TDF-FTC arm cases. In 11 of the 16 cases, detection of actual HIV infections was earlier than first site positive visit. One CAB case moved from incident to prevalent. No changes in HIV infection categorization happened in the TDF-FTCR. In some cases, CAB was initiated in participants who were already infected. In some cases, RNA and antibody tests reverted to negative or non-reactive early in infection. Viral load was often low at first HIV positive visit. And now we are moving to the TDF-FTCR. We had reported that we have identified 39 incident and 3 baseline infections. This did not change with the extended testing algorithm. Little bit of a complicated slide you are seeing here, but basically what you see here in dark black, dark gray, all the squares identification here represent the tenofovir diphosphate levels of each participant, which basically I will summarize for you here to show that basically 37 of the 39 incident infections can be well explained by poor adherence to the TDF-FTC. Resistance-associated mutations identified in the viremic specimens are also noted here in the slide. And these are the 2 participants whose HIV acquisitions are not explained by poor adherence. E16, you see in the blue open circles, had 7 or more doses per week on average, and the 2 most proximate time points and the solid blue circles are good evidence by plasma tenofovir of fairly consistent adherence, also proximate of the time of HIV acquisition. The participant did have a K65R and non-nucleoside mutations at detection, so that might have contributed to why they acquired HIV despite very good adherence. There is no M184V, at least by this consensus commercial genotyping. I can't tell you if there is low level of M184V here or not. E34 is someone who had very good plasma tenofovir evidence of adherence, but we are missing DBS specimen proximate to the HIV acquisition. So we can't say for sure that adherence was so. I can't explain it away by not adherence clearly. So that's why those are called out as 2 specific cases in the TDF-FTC arm. The key observations and conclusions we have so far is that we saw a 68% reduction in new infections when compared to active comparator TDF-FTC. Infections in the CAB arm were a rare event, 0.37 per 100 person years. Explanation for infections in the DKs remains subject of investigation. Infections in the CAB arm with integrase resistance were more rare, 5 among 16 infections. An active ARV regimen was able to be constructed in all cases. Most of the infections would have been detected using a sensitive viral load assay. And implications for testing algorithms for current and future long-acting PrEP agents need to be well considered. We had 4 incident infections in the CAB arm despite target plasma CAB concentrations, and there is ongoing evaluation of the correlates of protection. CAB-LA can delay detection of infection using standard HIV testing algorithm, as already mentioned. HIV integrase resistant when viremic escape at higher CAB concentration levels. That was a very important observation from our results. And this integrase resistance was not seen in the 3 tail phase infections or 1 tail escape case. And this was also a very interesting result that needs to be confirmed with long-term observation. TDF-FTC arm, we had 39 incident infections that had suboptimal or non-adherence as a reason. CAB-LA prompt seroconversions on CAB-LA need to have prompt diagnosis and ART initiation to avoid resistance. CAB-LA and TDF-FTC are both very effective, highly effective for HIV prevention. And in this study, CAB-LA was superior to daily oral TDF-FTC for HIV PrEP. We are moving in HPTN-083 with an open label extension phase that will stay for a year, and we will offer CAB-LA for all. We are offering CAB-LA to participants from the TDF-FTC arm. For those who decide to move, the oral lead-in phase will be optional. I would like to acknowledge our sponsors, the HPTN network, pharmaceutical support we have from ViiV and Gilead Sciences, the 43 sites in 7 countries, our community partners, our study participants, and the collaborators that helped me to prepare this presentation, especially Dr. Emilia Jalil. Thanks very much.